Question to the group. How does FDA/CMS and regulatory agencies define innovation? If we had a new test that will eliminate blood glucose testing and save lots of dollars, is this innovation? By the way, if you do have said product, I know several venture capitalists that would be extraordinarily interested in talking to you. But thought process, Rob, why don't you take a whack at how does CMS define innovation, and that'll give Jaron and Tom and Richard a chance to think about how the other agencies do it.
Right. Well, I think CMS looks at innovation in many ways. There are people in CMS that are looking at innovation in terms of the actual services that are provided to beneficiaries, the treatments. In my role, innovation, I think, was looked on a broader scale. More, when I think of innovation to a large degree, I think of it more in terms of the move toward providing people the means to better manage their health care, moving away from the traditional models which have been used to pay for services, looking at it on a more macro level than so much the micro level. I think there are, though, there's a center or a council within CMS, I think that was set up just to help with innovation, to help innovative kind of services or products to be covered, provide those kind of guidances. So CMS is aware of it, just not an area that I had gotten involved in as much. And when they talk about innovation, like the Center for Innovation, the Center for Innovation is looking at it on a more macro level.
More delivery system model shifts as opposed to a specific product.
Right, which is really what CMS is more about. As again, it goes back to its kind of underpinnings as a health insurance organization, a payer organization.
Right, Jaron.
Thanks. Earlier, or I should say middle of last year, the CMS actually formed a memorandum of understanding with the FDA. It was actually kind of quiet, not much news was made about it, but shortly thereafter came out a notice in the Federal Register about the intent of the FDA and the CMS to study the possibility of forming a parallel review process for technologies that were being presented to the FDA for clearance, which at the same time could begin the national coverage determination by the CMS. This was considered something novel. It had actually been tried before, so it's not that novel, but it was never done. CMS, FDA actually took comments on this idea of parallel review. The comment period ended about a month and a half ago, or about a month ago, so it's interesting to see what's going to come out of that. And the whole idea and emphasis for that was to really foster and promote innovation, safety and effectiveness, but at the same time trying to make sure that if someone, a company rather, puts forward a new technology, that they wouldn't have to wait thereafter, after receiving clearance, another year and a half to get a national coverage determination.
Yeah, but then there are precedents. Remember that process gives and it takes away. I mean, as if you look at drug-eluting stents, that was actually the first time that there was a parallel approval from an FDA and a CMS national coverage decision that was run parallel, and then literally a year later there were some very significant changes in that cover. Tom, do you feel empowering a patient with too many tools will allow them to start acting as their own physicians without any medical knowledge? Is there any danger to this?
Well, look, I mean, I think the internet has answered the question. Right? Most of us have been online more than once trying to diagnose an ailment or a lot that we're dealing with in our personal lives. And I don't think society is necessarily worse for wear. I think, to the contrary, I think involvement in the patient's involvement in their own care is absolutely essential in order to develop compliance in the type of new healthcare environment that I mentioned earlier, which is the one in which we've got most of the care being distributed outside of traditional facilities. Right? So if we're all going to, as we age, depend less on hospitals to take care of us and focus more on prevention, then we're going to have to be knowledgeable, we're going to have to use technology, feel comfortable with it if we want to live independently. And so I see it as a positive thing, not a negative thing.
Yeah, and the other opportunity with wireless health is going to be clinical decision support algorithms that will allow a physician to be looped in on an exception base. So we'll see that. In Ready, Aim, Fire, this is you, Richard, be ready. In Ready, Fire, Aim, excuse me, you mentioned reimbursement problems in the U.S. In your experience, would you recommend starting in Europe to maintain a healthy cash flow?
It worked for us. I think that, I mean, let's face it, we have the most complex healthcare system in the world in the U.S. And navigating through that system takes a lot of money and a lot of people and a lot of experience. And so from my standpoint, we got CE in Europe, and then we got TGA in Australia, then we came back for FDA. And it's worked well for us, so yeah, I think it's good to at least work in parallel internationally.
All right, any last question? Then often thought these functions are great to let people do a little networking and then talk to the panelists a little bit more one-on-one. So we'll throw as the last question, then we'll wrap it up. But any CMS requirement for reimbursement of Medicare that the patient has to be located at the originating site at the time of care? Jaron, when you nod, go to it, man.
Sure, I think that's, yeah, I was going to say, I think that's the entire requirement for CMS. If it's a telehealth consultation, it has to fit 5 different criteria. One of them being that it has to be live voice and video. It has to have an originating site of care. Both the doctor and the patient have to be doing it simultaneously, so there is no store and forward. It has to happen from a medical shortage area. You know, on and on and on. So by the time that you're done, a telehealth consultation or telemedicine, depending on if it's Medicare or Medicaid, really happens only you know, in 16% of the country. So it's a terrible impediment, especially in this day and age where we can do most things wirelessly. 3G mobile broadband has really bridged that gap. I mean, what's the one thing that everybody carries with them? Their cell phone. Arguably, you don't even need your keys anymore. You know, in certain smart services, same thing with money. You know, you can buy apparently Starbucks coffee now with your cell phone and pay for parking meters, etc. So, yeah, I think that's really the big criteria. And I'll pass it off to Mr. Benson because he obviously worked at this place.
Right. But I don't really think there's much more I can add. Again, I was in a different part of CMS, didn't get as involved in that part of it. I think Jaron knows probably more than I do, you know, about this particular aspect of CMS. So, defer his answer.
Great. So why don't we do this? First, I'd like to thank the Connect folks. It's a great, very, very good set of panels. And again, Tim, I thought we'd cut it just 5 minutes early because I know a lot of people want to pounce on the panelists one way or another. But again, thank you. Thank you, panelists, as well.
Thank you all for coming. I do want to, again, thank Buchanan Ingersoll for their drive in putting this together and their sponsorship. And they really thought of this topic and developed it. And we're really glad to see the response. I also want to thank Don Casey for agreeing to moderate this panel, and then for all of our panelists and presenters for coming out.